Hi, this is Scott Bergman at the University of Nebraska Medical Center. I'm giving a quick review on antimicrobial pharmacology, focusing on spectrum of activity, but including some on pharmacokinetics and pharmacodynamics, including what formulations each product is available in. I have these antibiotic charts that I share with students and residents and pharmacists about spectrum of activity. So now we're going to get to the bottom half of the card, which is the non-beta-lactams. Here, these drugs can include activity against MRSA, along with both species of Enterococcus, faecalis, and faecium that are most common. Back of my card has drugs that are mainly used for MRSA infections. Instead of listing out their spectrum that's primarily gram-positive, here I break it down into some unique features and what infections they may be most useful for. Also on the bottom is the mechanism of action diagram, where the bacterial static time-dependent drugs are on the left-hand side, the bactericidal drugs are on the right-hand side. We went over beta-lactams previously, which are the only truly time-dependent antibiotics, and the other ones can be considered more concentration-dependent. Starting with the aminoglycosides and polymyxins for gram-negative organisms, moving down my antibiotic chart, aminoglycosides are the only class that work against ribosomes, but are technically a concentration-dependent bactericidal antibiotic because they have a different mechanism that's not quite fully understood at this point. The main antibiotics you need to be familiar with are gentamicin and tobramycin. These are good for empiric double coverage for Pseudomonas, just in case that Pseudomonas in the ICU is resistant to one of your beta-lactams like piperacillin, tazobactam, or cefepime. These are the backup agents for patients that are critically ill. They have pretty poor penetration throughout the body, though. Their distribution is limited. So they're really that backup plan to keep bacteria from spreading out of the bloodstream. The one exception is the urinary tract, where they get excreted and have high concentrations. So you could theoretically treat a patient with monotherapy with an aminoglycoside for a UTI. Gentamicin is the only one of these that has synergy against Enterococcus. This is another use you'll see for the aminoglycosides when a patient has enterococcal endocarditis and they really need that bactericidal activity. This is combined with ampicillin or vancomycin. And those drugs, although normally bactericidal, have trouble breaking down Enterococcus because it has a really thick cell wall and they're only static against that organism. So by breaking up the cell wall, aminoglycosides then are able to get into the cell and work on the ribosomes, being able to synergistically work together and kill the bacteria. Against gram-positives on their own, they're just going to bounce off that thick cell wall. They won't be able to enter in to the cell and reliably kill the organism. Plazomicin is a new aminoglycoside that's good against multi-drug resistant strains, including carbapenem-resistant Enterobacteriaceae, or CRE. It hasn't seen a lot of use and is quite expensive, so it remains to be seen if this is really the new generation, or neoglycoside as it's dubbed, that we've been waiting for, that will be safer and effective. Polymyxin B and colistin are really old drugs. Right after penicillins were discovered and eventually approved and marketed, polymyxins came on the market to treat gram-negative infections. They have bad pharmacokinetics, they're very nephrotoxic, so we don't use them very much at all. They've fallen out of favor. They came back with the rise of CRE and really extensively drug-resistant Pseudomonas or Acinetobacter as well, another non-enteric. But because there's newer beta-lactams and other agents that work against these now, these are generally not preferred for any infection. You will see them in cystic fibrosis patients that have really bad resistance in their lungs. They can be inhaled. Especially colistin is the most common in that format. Moving through the antibiotic chart, keeping with the gram-negative theme, there's not too many oral drugs for gram-negatives, so trimethoprim-sulfamethoxazole, or Bactrim, is one of those that can be used for enteric gram-negative infections, but not Pseudomonas. It works pretty well for urinary tract infections because of that pharmacokinetic elimination through the urine. It's also effective for MRSA infections, so it's really seen a rise in its use in the last decade as community-acquired MRSA becomes more prevalent among skin infections. It's a drug of choice for some unusual bacteria like pneumocystis, nocardia, and stenotrophomonas as well. Another drug that comes up for skin infections and MRSA is rifampin. This is something that is really good against biofilm, that slime that attaches to the heart valves in endocarditis, or occasionally on the outside when I mentioned skin infections. We don't use it too much for cellulitis anymore, but when community-acquired MRSA was rising, it was recommended for a while to use it with a second agent like trimethoprim-sulfa. So now we don't do that much. We found that single agents are generally good enough. But for biofilm infections, endocarditis, or prosthetic joint infections, this is added on for a long time. It's also used in combination with TB over many months, but watch out for drug interactions with this because it is a cytochrome P450 inducer. Switching gears to more respiratory tract drugs, macrolides and tetracyclines, representatives of this class include azithromycin and doxycycline. Azithromycin is technically an azolide due to an extra member on its carbon ring, and that makes it a little more concentration dependent, which breaks the rule of ribosomal protein synthesis inhibitors being bacteriostatic and therefore time dependent. These are good for mild strep pneumo infections or Haemophilus influenzae, the respiratory gram-negatives, as well as atypicals like Mycoplasma or Chlamydophila. They also have fewer drug interactions, or I should say azithromycin has fewer drug interactions than the other older macrolides like clarithromycin and erythromycin, which is why you see it used more often, and it's also once daily. Doxycycline is a good representative sample from the tetracycline class. It's given twice a day, and similar to trimethoprim-sulfa, it's a good drug for MRSA infections, which I should point out the macrolides are not. If it's MRSA, it's almost always resistant to macrolides and azithromycin. But other than that, it's very similar to azithromycin's respiratory coverage, strep pneumo, Haemophilus influenzae, and the atypicals. It should be noted that this is not a great drug for enteric gram-negatives, and no tetracyclines have effective activity against either Pseudomonas aeruginosa or Proteus species, which is noteworthy because Proteus is generally fairly susceptible to the beta-lactams like ceftriaxone. Doxycycline is also a drug of choice for some unusual organisms. In this case, all of the tick-borne infections like Lyme disease, Ehrlichia, and Rocky Mountain spotted fever. There have been a number of new advanced tetracyclines come out in the last decade or so. Tigecycline is a glycyl cycline, so it has a larger side chain that makes it immune to the efflux pumps of a lot of bacteria. It has enhanced activity against MRSA and strep, as well as VRE. It treats most enteric gram-negatives, but not the typical Proteus, and also doesn't have activity against Pseudomonas. But it treats anaerobes and atypicals, covering all four of the major columns of my antibiotic chart. It had a lot of issues with tolerability, nausea and vomiting in clinical trials and practice, and it also has an FDA advisory against its use in severe infections due to increased mortality that was seen in the clinical trials. For that reason, it's not used very much anymore, but there have been some new developments really recently. Ravacycline has similar activity as tigecycline, but it's better tolerated. Right now, it's only approved IV, but there was an oral version studied, in clinical trials for urinary tract infections. Unfortunately, it doesn't get real great urinary concentrations, and it ended up not being able to show that it was non-inferior to the comparators, so it didn't get approved. And the IV form was studied with intra-abdominal infections. Works pretty well there when you think about its polymicrobial activity against gram-negatives and some gram-positives and anaerobes, but the oral version wasn't studied in that trial, so is not on the market. Omadacycline is the oral advanced tetracycline available now, and it is a little bit more like doxy and minocycline, which had the best gram-positive activity, really potent against those multi-drug resistant bacteria, and seems to be somewhat better tolerated than at least tigecycline. So new, it's hard to tell. We've only used it for a couple cases of mycobacterium infection, and that's one of its niche uses that is still emerging and we don't have a lot of data on. But those are pretty tough to treat, the non-tuberculosis mycobacterium. Fluoroquinolones have a long history, but there's only a few of them that are used primarily anymore. There's been actually more withdrawn from the market than are still on the market being used. These are all good for enteric gram-negatives, and if you're good for enterics, usually the rule is that you're also good for respiratory gram-negatives. These work intracellular on the nucleic acid. They do work against atypicals, which is somewhat unique. And then some used to have activity against staph or marketed that for that when they first came out. But in the infectious disease world, we don't consider these effective treatments for staph when used alone. Sometimes they're paired with rifampin. Rifampin gets resistant very quickly when used alone, and so do the fluoroquinolones for staph. They mutate into MRSA, so you're knocking out the beta-lactams as well as the fluoroquinolones with a single step mutation that happens after a few days of therapy. So ciprofloxacin is the oldest that's still being used. That's good against both enterics as well as Pseudomonas aeruginosa. So this should be noted. It's the only class of drug that is oral and effective against Pseudomonas. Cipro, though, is poor against most gram-positive infections. And that's where levofloxacin helped when it came around. It is better against Streptococcus species, including Strep pneumo, and has similar activity against enterics and Pseudomonas, as long as you use the higher dose, the 750 milligram per day, which is the max approved in the United States. That's because Pseudomonas has higher MICs. Just about every drug, this is true. You need to use the maximum doses to overcome that high inhibitory concentration. Moxifloxacin is a little different. It maintains the theme of working against strep and was marketed as a respiratory fluoroquinolone. It doesn't get eliminated through the urine, so it's not good for urinary tract infections like Cipro and levofloxacin, but it does have a little bit better anaerobic activity, so potentially could be used for minor intra-abdominal infections, but primarily it's marketed as a very potent strep respiratory drug for pneumonia. Just like with tetracyclines, there have been some developments in the fluoroquinolone class. There was a new advanced fluoroquinolone called Delafloxacin that was designed to be potent against MRSA and not have those resistant mutants occur. And it's also effective against strep pneumo and Pseudomonas. So this is the first drug approved in the US that can treat MRSA or Pseudomonas. Retains that good enteric gram-negative activity along with some anaerobes and atypicals. So it pretty much covers everything. We haven't used this a whole lot to know its place in therapy. Being so broad, we're a little nervous about abuse of this, but it's so expensive, as all new antibiotics are, that it's not being used in everybody right now. So we're still trying to figure out who's the best candidate that has resistant infection, that's tried some of the older drugs already, and being that it has an oral dosage form that could be really attractive. Other drugs that have anaerobe activity include clindamycin and metronidazole. Clindamycin also comes with gram-positive activity, including MRSA, coverage that is similar to trimethoprim-sulfa. It's a little bit better against community-acquired strains and tends to be used in kids a little bit more often. Adults have risk of Clostridium difficile, or everybody does, but it's a little bit worse in adults. So there's no gram-negative activity here. So I see that as a mistake being made in practice sometimes when this is used for intra-abdominal infection. It does have activity against anaerobes like Bacteroides, but a lot of the species have become resistant over time. It's over 30% right now, so it's not a very reliable drug for severe infection. Metronidazole is your go-to drug for anaerobic infections and abscesses where you really need to knock out those anaerobes. It isn't good for anything else though, so just think of it as the drug of choice for anaerobes. Now the anti-MRSA gram-positive antibiotics, this was the back of my antibiotic chart that I showed you. These are pretty much all approved for skin infections because that's where gram-positive organisms live. It's easy to get them on the market because they're fairly simple. Patients don't have to have a lot of comorbidities that complicate the results. Vancomycin is the oldest one, still the gold standard. Other drugs have not reliably beat this in clinical trials, but we do wonder about it sometimes in practice because it is very slowly cytal and has a lot of toxicity, especially acute kidney injury that comes with it. It does work against virtually all gram-positive organisms, except of course vancomycin-resistant enterococci. In the 2000s, we started to see a wave of new drugs for gram-positive infections. Linezolid was one of those that was available in an oral dosage form. It was really good for pneumonia and still is used for that, but this is a static agent that doesn't have very high bloodstream concentrations, so it's not a good choice for bacteremias. Tadazolid is the son of linezolid, designed to be once daily, more potent at a lower dose, tried to get around some of the side effects that linezolid had, like thrombocytopenia and interaction with the serotonin antagonists. It isn't used a whole lot, and we don't have much human data, so we're still cautiously watching that drug to see if it is as good as it's expected. It's also a brand name pricey drug where linezolid has gone generic. Daptomycin is another drug introduced in the 2000s that is very potent against MRSA, also has activity against VRE, although it was never FDA approved for that. There's just not a lot of market share to bother with the indication. Those patients are usually pretty sick. Enterococcus isn't a real virulent organism, so it's not as likely to kill patients if it's left untreated. In fact, there's many studies showing that it's just along for the ride, and if you kill the other more pathogenic organisms, the patient will recover just fine. It's good for bacteremia. This is a bactericidal antibiotic, a cyclic lipopeptide that works by depolarizing the cell membrane, essentially breaking it open and releasing electrolytes. The unique thing about this drug, though, is that it's inactivated by surfactant, so it's not good for pneumonia. Kind of the opposite role as linezolid, which was good for pneumonia and not bacteremia. This is one of the alternatives to vancomycin for bloodstream infections. Also safer, was pretty expensive and still is more pricey than vancomycin, but it's being used more as we can justify its use with a lower cost. The lipoglycopeptides are combinations of daptomycin and vancomycin structure. The glycopeptide is vancomycin, and the lipophilic tail on these is from similar to daptomycin's mechanism. Telavancin was approved in 2011. This was a once daily alternative for patients with pneumonia or bacteremia, but still comes with the nephrotoxicity of vancomycin. Dalbavancin and arutavancin are ultra-long-acting lipoglycopeptides, half-lives that last 7 to 10 days, and they can be given in one-dose regimens, or dalbavancin has a two-dose regimen approved. And we've started to experiment with these a little bit more for severe infections like endocarditis or osteomyelitis that need 6 weeks of therapy, but there is not a lot of clinical trial data yet with those. And then finally, lephemulin is the newest antibiotic that's been approved. It is active against resistant gram-positives like MRSA, strep, and enterococcus, including VRE. It doesn't have a lot of trial data or human use yet for that, but another oral drug for VRE is always appreciated in the ID community. It's going to be a respiratory tract drug first and foremost because it treats the respiratory gram-negatives and atypicals. Again, there's not a lot of drugs that can work against those atypical organisms like Mycoplasma, Legionella that don't have a real well-defined cell wall. So that's the end of my antibiotic review. I've put in a question or two here at the end to get you thinking. So you can either use the antibiotic chart I've got on the next slide again, or an antibiogram from your local hospital, or you can access ours online if you're on campus. Try to decide what antibiotic you could use for empiric therapy when you have a gram-negative bacilli that's growing in the bloodstream. You can imagine this is a hospitalized patient that you're looking for IV therapy in, but they're not so critically ill that they're in the ICU. And so you can choose based on what you think would be good for enteric gram-negatives and Pseudomonas if you don't have any rapid diagnostics. These are often from the urinary tract. We can imagine in this patient that it's a likely source, although it'd be also common to have somebody with intra-abdominal symptoms that enteric gram-negative could emerge from into the bloodstream. And if you do have rapid diagnostics or even urinary culture test that's growing bacteria, they can determine if it's a lactose fermenting gram-negative rod. That would lead you to treat for Enterobacteriaceae and not worry about Pseudomonas as much. If you look down the column for enteric gram-negatives that come from the gut, like E. coli and Klebsiella, you can see the early generations of penicillins are not really that strong. It's not until the third generation where you get pretty reliable activity. Depending on the part of the country or the world that you live in, you may have a lot of ESBLs. In Nebraska, we feel pretty comfortable in those non-ICU patients. If we have rapid diagnostics that say it's an Enterobacteriaceae, E. coli, or Klebsiella, to use ceftriaxone up front. We're still at the 90% or above mark for those. If you don't know what it is, if you just know it's a gram-negative, you have to consider Pseudomonas. Depends on the risk factors. If it's a urinary tract infection, that would be extremely unlikely coming from the community. If it's somebody that's been in the hospital for a week or two already, has a catheter-related infection, then Pseudomonas is much higher on the list. So for those, we're typically giving cefepime, piptazo, or meropenem as our workhorse anti-pseudomonals. You'd also want bactericidal drugs, being that it's a bloodstream infection. You want to eliminate it from the blood as soon as possible. Once you know what the source is and you know the organism, the susceptibility, you're going to think about definitive oral therapy. So in this case, let's say it's an E. coli that's identified from the urinary tract infection. This is a typical susceptibility pattern. You could argue ampicillin sulbactam is not always going to be a good choice. It has lower susceptibilities. For the purposes of the case, I left it as susceptible because you're thinking about oral drugs. Think about switching to from Unison to Augmentin, amoxicillin, clavulanic acid. They would have the same activity. Ceftriaxone, I said that's what we would normally go with. That it doesn't have a direct oral equivalent. We can see cefuroxime is intermediate. That's a pretty typical response or result. You could use cefpodoxime as an example, ceftonir, depending on your formulary. Those don't have real great oral absorption though, so it's controversial whether or not if this was the bloodstream infection, I should say that bloodstream infections using oral beta-lactams is controversial. Even in UTIs, they're known to be slower to respond to oral beta-lactams. They are eliminated renally, but the concentrations aren't as high as the alternatives. Trimethoprim-sulfa, fluoroquinolones tend to have the most data and get in the urine with really high concentrations. The other drugs here, gentamicin, meropenem, there's no oral equivalents. Piptazo and tigecycline, and you wouldn't use those for definitive therapy. So that leaves us with trimethoprim-sulfa here. I mentioned levofloxacin, also a effective option if it was susceptible. Our susceptibility rates are pretty similar between levo and trimethoprim-sulfa. If it was susceptible, there's the most evidence for short courses. If this was a bacteremia, levofloxacin has good bactericidal activity. Short courses of 7 days have been shown to be effective with gram-negative bacteremia. With a drug like trimethoprim-sulfa, it's considered to be more of a medium well absorption. And because it's time dependent, even though it gets good urinary concentrations, some people would continue therapy longer, like 10 or 14 days. Same with the beta-lactams. If it's an IV drug, like ceftriaxone, we feel comfortable with 7 days now based on the literature. But if switching to an oral beta-lactam, we may go longer, just like with trimethoprim-sulfa, closer to 14 days. So I hope that was useful for you. I can be reached at the email here if you have any questions.